Today we're going to continue with part two of medically compromised patients management in dental clinics. Now, we stopped last time at arrhythmia. Now, arrhythmia is considered or classified or defined as irregular heart rate. The heart rate is not regular, it's not within the normal range. Usually it's between 60 to 100. Now, tachycardia, it means the heart rate is above 100. Bradycardia, the heart rate is below 100, below 60, sorry. It can affect up to 15% of the population. Now, the physiology of it, we have three knots: the SA knot, the AV knot, and the bundle of His. Now, the SA knot is present. The SA knot is the controller of the heart. It sends the information. It gives the order for the heart rate to start. Sinus arrhythmia is not a true arrhythmia. Now, tachycardia, there are some risk factors for it: atropine, alcohol, caffeine, epinephrine, nicotine. All of those will cause increased heart rate. Bradycardia, it's caused by beta blockers, calcium channel blockers, digitalis, morphine. All of those can be causes that can cause bradycardia. Now, how can we manage arrhythmia? Simple, same, late morning appointments, but as we said in the beginning, supine position, the only cardiac condition that is treated in the supine position is arrhythmia. Aspirating syringe, local anesthesia. Now, which is better, mepivacaine or lidocaine? Mepivacaine or lidocaine? Now, lidocaine is antiarrhythmic, so it can be helpful to reduce it. So it's considered to be better. Now, mepivacaine is not contraindicated. It can be used if we don't have lidocaine for whatever reason. But we should be careful of what's something called methemoglobinemia. It can cause it. Mepivacaine and prilocaine. GA or sedation, they're both okay, but depending. If the patient is tachycardic, the heart rate in the operation should be high. If the patient is bradycardic, the heart rate should be low. Now, pacemakers, MRI, electrosurgery, transcutaneous nerve stimulation, these are all contraindicated. Now, some patients can place pacemakers. Now, we'll talk about them in a moment. These are the medications that can be given in these cases. Now, rheumatic fever. It's a beta hemolytic streptococci infection. It mostly affects children. Rheumatic fever transforms into chronic rheumatic carditis and then cardiac valvular damage. The valves will be damaged. Now, clinically sore throat followed by an acute febrile illness with migratory arthralgia, pain in the joints. Now, the features mainly, the heart itself will become fibrotic stiffness in the valves. The valves will become fibrotic. Now, the valves there should be like a balloon that they enlarge and then come back smaller, enlarge and come back smaller, with an opening that allows the blood to pass. Now, here in patients with rheumatic fever, we will have fibrotic stiffness, distortion of the heart valves, and sometimes, or most of the times, mitral stenosis. Now, acute rheumatic fever, they're not likely to be seen. Most patients with rheumatic fever are on anticoagulants. So here, we should consult the physician. Conscious sedation with nitrous oxide can be given if cardiac function is good with the approval of the physician. So, summary: any patient with rheumatic fever or any patient with valvular disease, we should refer them back to their physician, and then they give us the consultation. Use lidocaine with adrenaline or without adrenaline, and so on. Now, why do we talk about rheumatic fever? Because we have something very important after that called infective endocarditis. Now, this is a rare but potentially life threatening infection, predominantly affecting the damaged heart valves. Now, first, they become the valves are platelet fibrin deposits. Once it's damaged, there will be platelet deposits on the valve. After that, there will be sterile vegetations. Still, everything is fine. There will be aroma and stuff, but they're sterile. Then, large friable vegetations that are infected or have microorganisms. How? By bacteremia. Bacteria in the blood will cause this. How? The bacteria will be attached to the surface of the valve. Now, uncomplicated myocardial infarcts, coronary angioplasty, coronary artery bypass grafts, and pacemakers, they do not have an increased risk of developing infective endocarditis. Now, most bacteremias are transient, self limiting, but if we have a predisposing factor, a damaged valve, then there is a risk. Now, the clinical features usually there will be pale, the patients would be pale, cafe au lait pigmentations on the skin and joint pain, hepatosplenomegaly, enlargement of the spleen, the liver, progressive heart damage, and continuous valve damage. With fatigue, the patient is always tired. And this is the prosthetic valve and the damaged valve. Here we can see the vegetations on the valve. Now, what procedures can cause more damage or can cause infective endocarditis? Or another question that can be asked, or another form of the question, let's say, what are the procedures that can induce bacteremia? When there was a study, they found out that extractions up to 100% of bacteremias. Periodontal surgery, 36 to 88%. Scaling, root planing, 8 to 80%. Teeth cleaning, less than 40%. Endodontic procedures, less than 20% or equal to 20%. Wooden toothpicks, 20 to 40%. Water irrigation devices, 7 to 50%. Why am I talking about this? Because now we'll talk about something called prophylaxis. Antibiotic prophylaxis is important in cases when there is risk of infective endocarditis. Now, back then they found out that any patient with disease, with cardiac disease or valvular disease, should be given antibiotic prophylaxis before. But then they found out that anytime, anything we do can induce bacteremia. So it's not just that anything I want to go to the dentist, anytime I want to go to the dentist, I need to give the patient antibiotic prophylaxis. No, while brushing my teeth, I can have bacteremia. If I'm chewing food, I can have bacteremia. So that's why they came up with two guidelines. And we'll talk about them in a second. Now, usually patients would be anticoagulated. So, low molecular weight can be used. Now, we cannot measure it, but factor 10 can be used for both unfractionated and low molecular weight heparin. Half-life of unfractionated heparin is 1 to 2 hours, so we need to stop at 6 hours before the procedure. Low molecular weight has a longer half-life, so we need to stop it the night before the procedure, up to 12 hours, let's say. Now, in 2007, they recommended prophylaxis but only in high-risk circumstances. Patients with a history of infective endocarditis, the patient had infective endocarditis before. Prosthetic heart valve or artificial heart valves, they should be given. But then they found out that there are two types, biologic or synthetic or prosthetic. The biologic one, up to the first 3 months only, we need to give antibiotic prophylaxis. If it's prosthetic, we need to give at all times. Now, some congenital heart disease, unrepaired cyanotic congenital heart defect, completely repaired within the first 6 months with a prosthetic device, congenital heart defect, repaired with residual defects at the site or adjacent to the prosthetic patch, and cardiac transplantation who recipients who develop heart valve dysfunction. Now, in 2016, NICE guidelines or the British guidelines, they removed the need the antibiotic prophylaxis based on what we said that anything we can do can cause bacteremia. So why should we give prophylactic antibiotics? And sometimes they fail, and sometimes we have the risk of allergic reaction, sometimes we have resistant bacteria. So why should we give it? Why should we give it? So they kind of still in the debate, but what's agreed upon that if the patient has a history of infective endocarditis, artificial heart valves, these specific serious congenital heart disease, we need to give them antibiotic prophylaxis. So what should we give to these patients? Now, before, if the patient is able to take oral medication, amoxicillin 2 grams 1 hour before the procedure. Unable to take orally, we give ampicillin IV 2 grams or cefazolin or ceftriaxone 1 gram IM or IV. Allergic to penicillin or ampicillin, cephalexin, clindamycin, azithromycin or clarithromycin. Cephalexin 2 grams, clinda 600 milligrams, azithro or clarithro 500 milligrams. Allergic to penicillin or ampicillin and unable to take oral medication, cefazolin or ceftriaxone or clindamycin, IV or IM. Okay, so different conditions, different medications, simple. But later, let's say about 2022, I guess, if I remember correctly, clindamycin is no longer placed, no longer in the process of antibiotic prophylaxis for infective endocarditis. Now, the standard amoxicillin, unable to take oral medications, ampicillin or cefazolin or ceftriaxone, the same. Allergic to penicillin, cephalexin 2 grams, or first or second generation cephalosporins. Allergic to penicillin, azithromycin or clarithromycin. Allergic to penicillin also, we can use doxycycline. If we want something IV and allergic to penicillin, cefazolin or ceftriaxone. Now, cardiac failure. Any structural or functional impairment rendering the blood pumped to the organs as insufficient. The blood that comes out of the heart is insufficient. It's not sufficient to supply the whole body. There will be lack of tissue, organ perfusion, and will be reduced. Congestive heart failure is present. We have decongestive heart failure. A lot of things, we're not going to go through them. The mortality rate annually is 10%, and ischemic heart disease are the most common causes. We have left-sided or right-sided. The right side is more commonly associated with pulmonary or respiratory problems. Now we need medical consultation, of course. Local aspirating syringe. Bupivacaine is cardiotoxic, so it's contraindicated. GA is contraindicated, only local. And stress reduction protocol. So this ends the cardiovascular disease management. Now we will talk about the endocrine system. Since we talked about this in the very beginning, we're gonna skip. Now, the endocrine glands include the pituitary gland, the thyroid, the parathyroid, the pancreas, and the adrenal gland. Now, endocrine disorders can be either hormone excess, extra hyperthyroidism, hyperparathyroidism, or diminished hormone release, reduced release, hypothyroidism. Hormone resistance, type 2DM, which is considered resistant to the hormones. Now, we need to measure the concentration of the hormone, the plasma concentration to be specific. They have circadian rhythm. The levels varies through the 24 hours of the day. Now, first, we'll talk about diabetes mellitus. Diabetes means excess glucose in the blood, in the plasma. We have extra, more than usual. Now, the normal is up to 100. That's what we call normal, between 90 to 100, 105, 110. It differs most of the time, but usually this is the normal for the glucose level in the serum or in the blood. Now, it's the most common endocrine disorders. Now, insulin is secreted, as we said, by beta cells of Langerhans and glucagon by alpha cells. Insulin facilitates glucose transport into the cells and lowers the glucose. Glucagon stimulates the liver to convert it into glycogen and into glucose to raise the glucose levels. So they have different or opposing features, opposing functions. Once we have high blood glucose, the body will send an information to the pancreas to secrete insulin, which will reduce the blood glucose. If we have low blood sugar, like when we're fasting, glucagon will be secreted, stimulating the liver to convert it into glycogen into glucose to raise the blood glucose level. Now, diabetes affects about 3 to 4% of the general population, but 75% of those individuals can be seen. So, for example, we can see it in up to 2 or 3% of the population, but the remaining 1% we cannot know. Incidentally, found on the test, once the patient comes for routine tests, you found that he has high blood glucose. Now, risk factors include everything. Anything can cause diabetes. Stress can cause diabetes lately. So, not just genetics, not just eating a lot, not just not dieting. Sometimes stress can cause these medications. So, always these diseases. So, always try to reduce stress because it's killing us. Now, we have three types actually. Type 1, more common in Caucasians and European countries. Type 2 in African, Asians, and Hispanics. Clinical features: lethargy. Patients would be always tired. On testing, we will have hyperglycemia. Now, there's a simple term, the three P's: polyglycemia, high glucose; polydipsia, excessive thirst; polyuria, always going to the bathroom for urination. So these three P's, once they're present, a diagnosis of diabetes can be made. Now, severe cases, ketone bodies may be detected on the breath and accumulate into ketonemia, or excreted in the urine, ketonuria. Now, what are the types of diabetes? We have three types. Type 1, here we don't have any insulin. The body does not secrete insulin. And this affects up to 5 to 10% of all cases of diabetes, and most of these cases are children. Sometimes they call it the juvenile or the insulin dependent diabetes mellitus. The second type, or the most common, affecting up to 90% of the population, called non-insulin dependent. Here we have enough insulin. The insulin is sufficient, but there is resistance to the insulin. The receptors do not receive it.